Hello students, welcome to Module 8 of Adult Health 2. How exciting. You guys are at the end of another course on your way to be amazing, wonderful, smart nurses. Okay, so we're going to talk about acute pancreatitis. So again, itis is inflammation, pancreas. So it's an acute inflammatory process of the pancreas. And so it is where there is a spillage of the pancreatic enzymes into the pancreatic tissue, which causes autodigestion, which means it eats itself, and there is severe pain. So it can vary from mild edema to a necrotic pancreas. So it's most common in middle-aged women and men and affects them equally, but the rate is 3 times higher in African Americans than white persons. So it can be caused in women from gallbladder disease, this is most common, in men from chronic alcohol intake, from smoking, or from hypertriglyceridemia, glyceridemia. So gallstones, again, these are the most common problems, but smoking is an independent risk factor for acute appendicitis. So biliary sludge, which is a mixture of cholesterol crystals and calcium, is found in 20 to 40% of acute pancreatitis from bile stasis. And so they're also associated with this hypertriglyceridemia, so that's like serum levels of 1,000 or more. So why do we get it? It can be from trauma. You know, anytime an organ is hit with anything, it can get inflamed. From a viral infection, from a penetrating ulcer, from a cyst, or from an abscess. Less commonly, it can be caused from cystic fibrosis, from Kaposi sarcoma, certain drugs, from a metabolic disorder, vascular disease, or even an idiopathic cause where we don't know what it is. It can be caused by autodigestion of the pancreas, and so that's where the pancreatic cells are injured. So that could be where there's activation of those pancreatic enzymes in the pancreas instead of in the intestine. Activation of that trypsinogen to trypsin within the pancreas leads to bleeding. So trypsinogen is an inactive proteolytic enzyme that is produced by the pancreas. It's released into the small intestines via the pancreatic duct. In the small intestines, it's then activated to trypsin by enterokinase. So this is the pathogenic process. So again, the etiologic factors, or what causes it, that's the fancy way for saying what causes this. Alcoholism, biliary tract disease, trauma, infection, drugs, post-op GI surgery, or unknown. And then we have the activation of the enzyme, we have injury to the cells, and then with autodigestion, the effects could be edema, necrosis, hemorrhage, fat necrosis, vascular permeability, smooth muscle contraction, and all the way to shock. So alcohol is another common cause. The exact mechanism is unknown, but the thought is that alcohol may increase the production of pancreatic enzymes. So 5 to 10% of alcohol abusers will develop pancreatitis. And if they have a high-fat diet and smoking as well, it's even higher. So here's the I get smashed mnemonic. I just can't help myself. No, it's not true. Idiopathic, gallstones, ethanol, trauma, steroids, mumps or malignancy, autoimmune, scorpion stings, hypercalcemia or hypertriglyceridemia, ERCP, and drugs. So mild pancreatitis could be edematous or interstitial, and then severe necrotizing, if there's necrosis, that's death, and that's never a good thing. Endocrine and exocrine dysfunction, necrosis, which could lead to organ failure and sepsis, and the rate of mortality with acute pancreatitis is 25%. So it's so common that I think we don't think it is severe as it is, but yes, 1 in 4 people die from pancreatitis. This is what an acute pancreas looks like. So what are the clinical manifestations? How will they present? What are the cues? So left upper quadrant pain or mid-epigastrum. It radiates to the back. It is sudden. It is deep, piercing, continuous, or steady. It can be aggravated when they eat. It starts when they're recumbent and is not relieved when they vomit, although they will probably be vomiting. Flushed, cyanotic, dyspnea, nausea, vomiting, a low-grade fever, leukocytosis, hypotension, tachy, and jaundice. You see a lot of these same things, even when we talked last week, like when you have abdominal pain, it's like it could be so many things. It's, difficult to diagnose and figure it out. Your stomach hurts, you have nausea, vomiting, a fever, and it could be just so many things. So they'll have abdominal tenderness with muscle guarding, meaning when they say guarding, that means you're holding it and you're guarding it because it hurts so bad. Decreased or absent bowel sounds. There might be crackles in the lungs. There might be abdominal skin discoloration like gray Turner's spots or a Cullen sign. There might be shock or a pseudocyst, and that's where there's fluid, enzyme debris, or an exudate that's surrounded by a wall. Abdominal pain, a palpable mass, nausea, vomiting, anorexia. It's detected with imaging, and it resolves spontaneously. The complications might be a pancreatic abscess, like an infected pseudocyst, results from extensive necrosis. It might rupture or perforate. There might be upper abdominal pain, mass, high fever, and it requires prompt surgical drainage. The systemic complications might be a pleural effusion, atelectasis, pneumonia, ARDS, hypotension, thrombi, pulmonary embolism, DIC. They could have tetany from hypocalcemia. And how are we going to know? What are the diagnostic studies going to show? Serum amylase levels, serum lipase levels, liver enzymes, triglycerides, glucose, bili, and the serum calcium levels. So we want to look at all of these things to try to figure out what's going on. Abdominal ultrasound might be used to diagnose, or an X-ray, or a contrast-enhanced CT, or an ERCP. A CT scan is the best imaging test for pancreatitis and related complications such as cysts and abscess and all those things. Endoscopic ultrasonography can be used, an MRCP, where there's cholangiopancreatography, angiography, or a chest x-ray. So we're going to need to relieve their pain, which is very severe, prevent or alleviate shock, decrease those pancreatic secretions, correct their fluid and electrolyte imbalances, prevent an infection, and remove whatever is precipitating it. For supportive care, it's conservative. The conservative is, aggressive hydration, manage their pain with like morphine or antispasmodics, manage the metabolic complications with oxygen or glucose, minimize pancreatic stimulation. They will absolutely be NPO because we want no stimulation of the pancreas. And when you eat or drink, you have stimulation of the pancreas. They will probably have NG suction, decreased acid secretion, and they'll have enteral nutrition if needed. So the treatment is really just focused on that supportive care. But the control of pain is very, very important because it is so very painful. And so when it resolves, then we can resume oral intake. Conservative treatment again, plasma or plasma volume expanders if there's shock involved. With fluid and electrolyte imbalance, they will probably have lactated ringers. Ongoing hypotension, we will give vasoactive drugs, and to prevent infection, we need enteral nutrition because that boosts the immune system, antibiotics, and then endoscopy or a CT-guided percutaneous aspiration with gram stain and culture may be performed. For gallstones, ERCP or a cholecystectomy might be an uncertain diagnosis, not responding to conservative therapy, or if we need to drain necrotic fluid collections, because patients that have a severe acute pancreatitis might have to be drained. It's done surgically, under CT, or endoscopically, or endoscopically. Percutaneous drainage of a cyst can be performed, and they might put a drainage tube in place depending how bad it is. For drugs, they will need morphine, antispasmodics, carbonic anhydrase inhibitors, antacid, protein pump inhibitors, because we need morphine for pain. The antispasmodics are to decrease that vagal stimulation and the pancreatic outflow. The carbonic anhydrase inhibitor decreases the pancreatic secretions. Antacids neutralize the acid, and so do the proton pump inhibitors. They'll need NPO status initially. They might need enteral or parenteral nutrition. Monitor those triglycerides if IV lipids are given. Small, frequent feedings as soon as they're able with high carbs, no alcohol. And we need to supplement the fat-soluble vitamins. They really need to abstain from alcohol. So nursing interventions. Pancreas. This is how you remember. Pain, we need to treat their pain. Antispasmodics, NPO, calcium. replace their fluid losses, endocrine and enzymes, antibiotics if they have a fever, and steroids during acute attack. We will, for their history, we'll look and see, do you have biliac tract disease? Do you drink alcohol? How much? Have you had an abdominal trauma or an ulcer, an infection, or a metabolic disorder? Medications, are they on thiazides or NSAIDs? You know, NSAIDs cause a lot of problems, overuse of NSAIDs. Have they had surgery to their pancreas, stomach, duodenum, or biliary tract, or an ERCP? Because an ERCP can actually cause it as well. Okay, so subjectively, alcohol, fatigue, nausea, vomiting, anorexia, dyspnea, and pain, severe mid-epigastric or left upper quadrant pain. So objectively, are they restless, anxious, fever, flush, diaphoretic, discoloration, cyanotic, jaundice, decreased skin turgor, dry mucous membranes, tachypnea, crackles, tachycardia, hypotension, abdominal distension, or diminished bowel sounds? Possible diagnostics, we will see an increase in their amylase and lipase, leukocytosis, hyperglycemia, hypocalcemia. We're going to have abnormal findings on the scans and abnormal findings on the ERCP. It's funny because the ERCP can be used to diagnose, but it can also cause problems with the pancreas, so it all depends. Nursing diagnoses: acute pain, deficient fluid volume, imbalanced nutrition, or ineffective health management. Certainly, because a lot of people are repeat customers when it comes to pancreatitis. When we see people with alcohol abuse, it's very sad that they cannot get it under control and then they just keep having issues with their pancreas. What do we want? We want them to have relief from pain. We want to be hemodynamically stable, not have all those awful complications, and certainly no recurrent attacks. Once we figure out what causes it, we're really hoping that they can adhere to a really good plan to not have this again. Health promotion, we're going to assess the patient for predisposing and etiologic factors. We're going to encourage early treatment, early diagnosis, elimination of alcohol. For acute care, we want to monitor vitals, monitor how they respond to IV fluids, closely monitor their hemodynamic status and their respiratory function. So acutely, we're going to want to monitor their fluid and electrolyte imbalances with chloride, sodium, potassium. We're going to watch for hypocalcemia to make sure they don't have tetany or calcium gluconate. We're going to give calcium gluconate to treat, and then also watch for hypomagnesemia. So this is why we need to monitor for tetany. So Chauvet sign is a contraction of the facial muscles in response to a light tap. And so all you do is you just type on their face and the muscles would do that, and that is a sign of tetany. And then also you can look at their carpal tunnels, their carpal spasm, that's initiated by putting a blood pressure cuff on their arm. So those are two ways to see if if it has progressed, their hypocalcemia has progressed to tetany. So the nursing implementation for acute pancreatitis, because pain is one of the biggest problems with pancreatitis, we are going to give morphine. We want to position them for comfort with frequent position changes. So we want them to flex their trunk and to draw their knees to their abdomen, and then sideline with their head of the bed elevated. We don't want them to lie flat. They really will need morphine though, because it is so painful in those position changes. They need frequent oral and nasal care. Especially because they're NPO, they can end up with problems. We don't want them to have any super infections going on. We want to administer an acid, observe for signs of infection. They need to be in a semi-Fowler's position. They may need wound care. We're going to need to observe for perilytic ileus, renal failure, mental changes, monitor their glucose, and post-op wound care. For ambulatory care, we need, because of the loss, they might need physical therapy. We need to assess for opioid addiction. We need to counsel regarding abstinence from alcohol and smoking to prevent recurrence of pancreatitis, which is so very common. Smoking also stimulates the pancreas, and so it really needs to be avoided. Dietary teaching, a low-fat, high-carb diet, no crash diets. That's also a problem. We need to teach the family to look for signs of infection, diabetes, steatorrhea, and look at their medications and diet. If it's chronic, if they have continuous, prolonged inflammation and fibrosing process of the pancreas, this could be because of alcohol, because of gallstones, a tumor, a pseudocyst, trauma, or systemic disease. It also because they continue to have acute pancreatitis over and over, or it could just be an idiopathic cause that we have no idea why someone has chronic pancreatitis. So the two types of chronic pancreatitis are chronic obstructive pancreatitis, where there's inflammation of the sphincter of Oddi. And that also could be because of cancer of the ampulla of Vater, the duodenum, or the pancreas. It could also be chronic non-obstructive, and that's where there's just inflammation, or the head of the pancreas and around the duct is sclerosed, causing the inflammation. The most common cause of chronic non-obstructive is alcoholism. So what does this look like? What are our cues? These patients are going to present with abdominal pain, so that is located in areas just like acute pancreatitis. There's a heavy gnawing feeling like burning and cramp-like, and it's in the same place, the same areas as acute pancreatitis. The pain is not relieved with food or antacids the same way. They may have episodes of acute pain, but it is usually chronic. The clinical manifestations, they'll have malabsorption that causes weight loss. They might be constipated, mild jaundice with dark urine, steatorrhea, diabetes, and there's lots of complications that can happen. With pseudocyst formation, bile duct or duodenal obstruction, they could have ascites in their pancreas requiring, they might need the fluid removed. Pleural effusion, splenic vein thrombosis, a pseudoaneurysm, or even pancreatic cancer. This is certainly a risk for pancreatic cancer. The diagnostic studies, we're going to need to look at their serum amylase and lipase, bilirubin, alk phos. They might have mild leukocytosis or an increased sedimentation rate. For diagnosis, again, we might use an ERCP to visualize the pancreas and common bile duct, and then all these other scans that might be used to get a good look. We might need to do a stool sample for fat content, decrease fat-soluble vitamins and cobalamin levels. They might have a glucose intolerance or diabetes, and then they may need a serum, a secretin stimulation test to diagnose the pancreatic dysfunction. Interprofessionally, they're going to need analgesics, and so either morphine or a fentanyl patch. Bland diet, no smoking, no alcohol, and no caffeine. Pancreatic enzymes might need to be replaced, as well as bile salts. They might need insulin or oral hypoglycemic agents because obviously the pancreas is responsible for managing the release of insulin when we need it. And so if the pancreas is inflamed and not functioning, it could also affect people's glucose levels. They might need acid neutralizing or acid inhibiting drugs, or even antidepressants, which antidepressants have been shown to reduce the neuropathic pain that happens when somebody has chronic pancreatitis. The endoscopic procedures, they might need pancreatic drainage or the ERCP with a splenectomy or a stent placement. Surgery will be needed if there is a cyst, or if they need to divert flow so that so they don't end up with a ductal obstruction, or all sorts of different surgeries depending on what the cause is, or what they need to reroute, or what the complications are for that individual. Of course, the focus is on chronic care and health promotion. We want to teach the patient and the family, especially if they are very bad and need family to take care of them, their diet, pancreatic enzymes, to observe for steatorrhea, to monitor glucose, to give antacids after meals and at bedtime, and to abstain from alcohol. And if they are dependent on alcohol, then we have to call in other agencies, or they're just going to be repeat admission after repeat admission for pancreatitis. Okay, gallbladder disease. So cholelithiasis is the most common disorder of the biliary system, and that's where gallbladder stones. Cholecystitis is inflammation of the gallbladder, and that's usually caused from a gallstone. So people that are at risk are female, multipolarity, age older than 40, estrogen therapy, a sedentary lifestyle, if there's a familial tendency, and obese. So cholelithiasis, that's the cause. The cause of gallstones is unknown, but they develop when the balance that keeps cholesterol, bile salts, and calcium is changed, leading to precipitation that causes these stones. So bile is secreted by the liver that is supersaturated with cholesterol. And then the stasis of the bile leads to supersaturation and changes to bile. And so immobility, pregnancy, inflammatory obstructive lesion in the biliary system, or decreased bile flow can all be causes of having gallstones. The stones may stay in the gallbladder, or they can migrate to the cystic or common bile duct, and they cause pain when they pass through the ducts. And that's what people present with in the ER is abdominal pain. And they can lodge in the ducts and then cause obstruction. So this is what a gallbladder with gallstones might look like. Cholecystitis is most often associated with obstruction from stones. So older adults and critically ill are at risk from prolonged immobility, fasting, prolonged parenteral nutrition, or even diabetes. The inflammation can be confined to the mucous lining, or the entire gallbladder can be edematous and hyperemic, and it might be distended with bile or pus, and there can be scarring and fibrosis that occur after attacks. And so that's why it's really important that people get it under control. So the clinical manifestations, they can vary to very severe, or people might not have any symptoms at all. So the pain becomes severe when the stones are moving or they're obstructing something, and it can be steady, excruciating pain that causes tachycardia, diaphoresis. There might be residual tenderness in that right upper quadrant, and it typically will occur 3 to 6 hours after a high-fat meal or if they lie down. When total obstruction occurs, they might have dark amber urine, clay-colored stools, pruritus, intolerance to fatty foods. They might have bleeding tendencies and steatorrhea. In addition to pain, they might have indigestion, fever, chills, jaundice, nausea, vomiting. They might be restless from the pain, diaphoretic. They could have leukocytosis or fever. And on physical exam, you will find that they have right upper quadrant or even epigastrium tenderness, and an abdominal rigidity, depending on how bad it is. So if it is chronic, they will have, you'll hear people say, oh, I'm on a specific diet because I have gallbladder problems. They really need to have a low-fat diet. They can have dyspepsia, heartburn, and flatulence because of this chronic cholecystitis. But the problem is it can end up gangrene. So anytime we have an organ that is inflamed, that has possible stones, it can obstruct and become gangrene, and then that's an emergency anytime we have an organ that ends up gangrene. They can have subphrenic abscess, pancreatitis, cholangitis, biliary cirrhosis. They could end up with a fistula. The gallbladder could rupture, leading to peritonitis. Remember when we talked about peritonitis, and anytime an organ ruptures or has problems, you end up with an infection in the peritoneum. Or choledocholithiasis. So to diagnose, they might need an ultrasound, an ERCP, a percutaneous transhepatic cholangiography, or all these lab tests. We're going to look for abnormalities to indicate stones. So cholelithiasis, the treatment is dependent on the stage of the disease. And then they might need oral dissolution therapy, which might help break up those stones. If they have ESWL, which is extracorporeal shockwave lithotripsy, and so that is if the stones cannot be removed with the endoscope. It is a high energy shockwave that disintegrates the gallstones, and it can take 1 to 2 hours, and it is used in conjunction with bile acids. For surgery, they might just need a lap chole. That's the short term for lap chole. It's a laparoscopic cholecystectomy. That is the treatment of choice, and a lot of people have that done. That's to remove the gallbladder. They put in 1 to 4 puncture holes to remove it. They really have minimal postoperative pain, and then they resume their normal activities with few complications. An incisional open cholecystectomy. So a lot of times, you'll prep a patient and you'll tell them they're going to have a lap chole, but you have to always tell people you never know if something goes wrong or they can't get to it, or sometimes with obesity there are certain reasons why someone might need an open chole, meaning they can't just make the 4 little holes and go in. They have to actually do an incision and do an open surgery, and that's where it is removed through like a right subcostal incision, and a T-tube is inserted into the common bile duct. That ensures the patency of the duct, and that allows all of that excess bile to drain. And so this is a picture of that. So the transhepatic biliary catheter, and so that might be either preoperative or palliative. It's inserted percutaneously and attached to a drainage bag. That sometimes will be done in radiology, believe it or not. Like radiology departments will have an interventional radiology department where they do various procedures like this. And for this we need to replace the fluids that are lost with electrolyte-rich fluids and make sure we take care of the skin. Skin care is really important anytime anyone has a drain, because the skin area right around the drain can get really excoriated and raw and then cause another infection. So drugs, they'll need analgesics such as morphine or anticholinergics like atropine. We need to replace their fat-soluble vitamins and also give bile salts. Nutritionally, they need small, frequent meals with some fat, diet low in saturated fat, they need high fiber. If they're obese, we really need to have them have a nutritional consult to reduce their calorie intake. They need also, though, to avoid a rapid weight loss. It's just like with everything else. You can't have like too quick of changes. You don't want to gain weight too quick. You don't want to lose weight too quick. These all can really disrupt, so many symptoms. So after a lap chole, they'll need liquids the first day and then light meals for a few days. If they have an incisional chole, they're going to have a liquid to a regular diet once we have bowel sounds that have returned. It's super important that no one has anything by mouth until we make sure somebody has their bowel sounds returned after surgery. And they might actually need to restrict their fast for up to 6 weeks. Nursing diagnoses for this might be acute pain or knowledge deficit. The goal, we want to relieve their pain and discomfort and not have post-op complications and no recurrent attacks. But a lot of times people have recurrent attacks and you wonder why they take so long to just have surgery to have it out. For health promotion, we want to screen for predisposing factors. There are certainly at-risk ethnic groups. We want to detect chronic cholecystitis and try to manage with a low-fat diet. Acutely, we're going to treat their pain. We want to relieve their nausea and vomiting, provide comfort, fluid and electrolyte imbalance, and observe for complications. Acutely, we want to give drugs for pain, observe for side effects. For their nausea and vomiting, they may need an NG tube to decompress gastrically. We want to make sure they have good oral hygiene and care of their nares, and so they don't have any problems with their skin, antiemetics, and certainly comfort measures. We want to monitor for complications such as an obstruction or bleeding or infection. Post-ERCP, we're going to assess for complications by checking their vitals, pain, bed rest. They're going to be NPO until the gag reflex is returned, and make sure we give them plenty of patient teaching. Post-operatively, if someone has a lap chole, we want to monitor for complications. For patient comfort, they might have referred pain to their shoulder from the CO2. We need them to be in the Sims position and to have deep breathing, ambulate, and to provide good analgesia, clear liquids, and most of the time they're discharged the same day. Postoperatively, we need to maintain adequate ventilation. We need to look for and prevent respiratory complications. General post-op, maintain any drains that are there, and then replace their fluid and electrolytes. Expected outcomes, we want them to appear comfortable and not have any pain. And to assess their knowledge. Thank you so much. Have a great week.